Hi, everyone. My name is Pooja Prasad, and I'm a cardiology fellow at OHSU. I'm part of the Fit on the Go program, and I'm so honored today to be joined by Dr. Ahmad from Yale, who will be talking to us about prompt HF. I think I will just start off by saying that in my own clinic, I really enjoy up titrating medical therapy and getting patients on guideline directed medical therapy. But we, of course, know that that's a big challenge in our field in heart failure to make sure that all of our patients are on these life saving medications. And, I really enjoyed hearing about this late breaking clinical trial in the main tent at ACC. So, Dr. Ahmad, why don't you start off by telling us a little bit about what the inspiration was behind this study?
Absolutely, Pooja. So thank you so much for inviting me. Heart failure has existed as long as human beings have written about medicine for thousands of years, but it's only until recently that we have good treatments for it. We have medical treatments that can prolong patients' lives, make them feel better, have them stay out of the hospital. I ask house staff on rounds, like, what percentage of patients do you think would be on these life-saving therapies? There's four pillars of these medications now. So beta blockers, ACE, ARNI, MRA, and SGLT2 inhibitor. And they all guess that it should be 70, 80, 90%, but they're surprised when I tell them that it's less than 5%. Both from national registries and even at our center, which is almost identical to national registries. So, we collected data on all the heart failure patients within the Yale New Haven Health System, which is one of the largest academic health systems in the country. And we found that not only does the data mirror the national registry data almost in an identical fashion, but there's huge gaps in treatment. So for this reason, we designed the Prompt HF study that that hoped to use the electronic health record to its full potential, where we used the EHR to essentially analyze data on individual patients and help the clinician out. Because as you mentioned, when you're in clinic, these patients are complex. There's a lot of stuff going on. You have 15, 20 minutes to make a lot of decisions. This way, it's man and machine coming together to essentially nudge the clinician into getting these patients on the right therapies and helping them along. So it's not intrusive. And that was the hypothesis of the study, that if we nudge clinicians or prompt clinicians, make it very easy for them, then they will get their heart failure with reduced ejection fraction patients on the right therapies.
Okay. Yeah, so I'd love to hear now about I know that you both had a primary outcome and a secondary outcome. I was interested in, how you went about deciding on which outcomes to look at. Of course, there's a lot of different data you could be gathering here.
Absolutely, Pooja. So that's a fabulous question. This was a cluster randomized trial that was randomized at the level of the clinician. We wanted to make sure that we have a very kind of an outcome that is clinically meaningful. So, and our outcome was the addition of a guideline-directed medical therapy. So if you went from a beta blocker to a beta blocker and an ARNI, for example, that would be considered a positive outcome. Just an increase in dose could have been considered a positive outcome, but we wanted to shoot for a slightly higher than that. So that for that reason, we made our primary outcome to be the addition of a class of medication, which is how we designed the study. So as you could read up in Jack online. The clinicians were prompted on what medications their patient was on, and then what additional GDMT they should be on. So if they were on beta blocker, ARNI, and MRA, the prompt would essentially tell them that they are not an SGLT2 inhibitor, and if you want to prescribe an SGLT2 inhibitor, you can click here. So that was the primary outcome, the addition of a class. And we found that at 1 month time, and take into account the fact that there were very aggressive efforts across our health system to get patients on GDMT because of quality kind of heart failure is a corporate objective at Yale New Haven Health. So everyone's been focusing on it. So you would expect essentially everything to go up. And we found that in the usual care arm, it went up by 18%. So 18% additional patients were on a GDMT class added at 1 month. But in the prompt arm, it was about almost 26%. So the number needed to alert, so the number of patients needed to alert for an additional class of GDMT to be added was only 14. And when we looked at our secondary outcome, which was addition of a class or up titration of a medication, the number needed to alert for that was only 10. So in both regards, it made a positive impact on getting patients on the right therapies.
And I understand that for one of your secondary outcomes, you also looked at heart failure hospitalizations, and we did not see a change in heart failure hospitalizations. Is that correct?
That's absolutely correct, Pooja, and it's a very astute observation. So this was a pretty stable population. They were all outpatients, so we would not have expected to see a very, very high rate at 30 days, which is what we looked at. But we're following the patients right now, and we're going to report on 6-month and 1-year outcomes in terms of readmissions and hospitalizations. So I think that I'm hypothesizing that there will be a signal with longer follow-up. But the hospitalization outcome at 30 days was primarily to make sure that there was no safety issues. So there was concern that, if you get people on GDMT, maybe they get hypotensive or something like that. So there are a lot of clinician concerns about getting people on GDMT that we wanted to make sure don't occur as with any randomized control trial.
Yeah, that's really helpful to better understand what you were doing there with that secondary outcome. That makes a lot of sense that in 30 days you just want to ensure safety. I've definitely heard so many different arguments for why people justify not starting a variety of, life-saving heart failure medications. So, you're not seeing increased hospitalizations in 30 days, which is good. Of course, that's really exciting to hear that you're going to continue following these patients as well. And I'm really curious to see what you'll find. I wouldn't be surprised if maybe we did see a decrease in heart failure hospitalizations over the course of a year if we were to follow these patients.
Absolutely, and the alert was shut off after the study was completed, and we're going to turn it back on. So we're going to have this fascinating look to see what happened in the absence and then the re-presence of the alert. So these are all exciting questions as we get into this implementation science field where we have really good therapies for heart failure, but it's their implementation that's the big challenge now.
So I guess I'm curious, after you're done with this trial, like how do you see implementation going, both at your own institution at Yale and also, beyond Yale? Of course, with drug clinical trials, there's a process, but I found that in this type of clinical trial, I'm interested to see how you see this being adopted.
Pooja, that's an excellent question. I think moving forward, we should have the implementation arm as a natural extension of any randomized controlled trial. So, for example, like Entresto, when the Paradigm HF trial was presented and published, there was a gap of years before we got patients on the right therapies, and that should not be the case. So I think that moving forward, we should have these implementation studies built into the original study. As a second question about where to go from now, I think that this is a very easy intervention that can be taken up at any institution that uses the EHR. So all they need to do is we can share our code with anyone who wants it, and they can make modifications based on their health system and then use it, and hopefully it will make a positive impact. A third thing is that this is only the tip of the iceberg. So, we know from outside of medicine that when you are dealing with complex and lots of data, computers are much better at analyzing that data and making sense of it than human beings are. So we have the EHR with, billions of data points that are generated every day. And we really need to kind of move beyond the fact where you're entrusting clinicians with, with all their kind of differences in knowledge base and emotion and all that sort of stuff, whereas the computer can kind of analyze all that data and basically help you make the decision of how what needs to be done. So moving forward, I think that we need to have these algorithms running in the background and essentially advising us about what the best decision is, because the human factor is going to be is not going to be coming from computers, but we need to let the computers do what they're good at, and then human beings do the human aspect of medicine, which is a lot trickier.
Yeah, those are amazing points. I think that, this is obviously, our ability to apply technology to patient care can have such a big impact on this population. And we already know that heart failure is, such a big, resource. I mean, there's so many resources that go into taking care of these patients. If we're able to, more efficiently take care of these patients, then perhaps we could make an impact at a population level.
Absolutely, Pooja. I mean, if you think about, X-rays, for example, like, do you really need human beings like sitting there reading X-rays or ECGs, right? Computers can do this much better. So you want human beings, taking in all the data and then making decisions based on that for their individual patients. So kind of taking that level of, integrate, doing stuff that the human mind is not as good at, and applying it to work with the machine as you would do with a self-driving car, for example, right? Like, you need the human beings there, but computers can also do some things pretty well. So I think that's kind of the future of where we're heading, so that we can drive down costs and we can make medicine a lot more efficient and more patient-centered.
Well, thank you so much, Dr. Ahmed, for sitting down and talking to me virtually. It was really nice to meet you at ACC, and thank you for all your work and all your colleagues' work as well.
Thank you so much, Pooja. It was a real honor to be here, and thank you so much for inviting me.